And we are like finishing where we started, coming back to the families, because I mean, this is the whole point of neonatal care. We sometimes focus a lot on diseases and treatments and so on, but it's the patients and the families that matters most, of course. I was just thinking about this. There was someone who said that the outcomes they had measured weren't so good. They were not Bailey's, but ability to walk and talk and those kind of softer outcomes. I think that those kind of outcomes are probably more understandable and also to some degree more relevant to parents, as I see it. And in the panel today, it's Ryo Otishima, Mandy C Daly, and Lien. So welcome here. And we're starting off already with a poll.
Well, yeah, apparently so. I think this is.
Sorry, I forgot to put one more slide at the beginning.
So do you want to, shall we keep it open?
Well,
Yeah.
let's start with that, and I will open it later
Okay,
because I have to introduce myself
yes.
first.
But I give the word to you, so please.
Thank you. So good afternoon again, everyone. So again, my name's Ryo, as I told you before, and well, let me introduce myself a little bit. Well, I'm a Japanese, but now I'm living in Finland for, well, actually many reasons. So, well, my background is a neonatologist and a pediatrician in Japan. So well, until 2020, I was working as a neonatologist in one of the NICUs in Japan. But then I moved to Finland. Then, since then, I have been studying, well, family-centered care, actually. This is my, well, topic as a PhD student. And, well, I'm doing my PhD at the University of Turku in Finland. So it's my pleasure to be here. And it seems that you're already so exhausted. And me too, of course. And but let's start. Well, actually, my presentation is not at all very difficult one or not many data or something. It's more interactive one. So I'd like to, well, talk more with you. Okay, good. So I would like to start with this question. So today's topic is something about family or parents issue or, well, things. So I would like to ask you if well, we should take families into account in NICU care. Okay. No surprise, of course. Thank you. Thank you. This is what I have expected because, well, it's already written in many, well, places like guidelines by WHO or something. So there is no doubt we should or we must take families into account in NICU care. But, well, talking about history, like 50 years ago, for example, maybe the situation is different, was different. So during that period, I'm sure, well, I was not there 50 years ago, but well, during that period, of course, parents were mostly, I heard so, excluded from the NICU or NICU care. So if I were asking these questions to those who were working in the NICU during that period, I'm sure some of them might say not necessary. But we have changed our mind since then. So nowadays, of course, at least we think or we believe that we definitely need parents in the NICU care. So this is a history. And let me talk a little bit about my history or myself. Oh, sorry. Okay, so as I told you, well, until 2020, I was working in NICU in Japan as a neonatologist. And it was 2018, I think, that, well, I was working in Nagano Children's Hospital. It's level 4 NICU, one of the level 4 NICUs in Japan. And there we had this very, very tiny infant who was born weighing 258 grams. But very, very luckily, he survived. He grew up very quickly. And after, well, eventually he was discharged home without any severe complications. And now I'm sure he's about 5.5 years of age, and he's still healthy. And on the right side, you can see the screenshot of the YouTube video showing how he was doing at the 4 years of age. And I was so happy to see that he's, well, of course, doing well, but the whole family seems very, very happy. So this is what I felt. Maybe it was last year or something. But well, talking about when I was working in the NICU in Japan, it was about 5 years ago. Well, my brain was different. So you can see, well, on the left side, this picture was taken maybe 1 or 2 days after delivery. And when this baby was successfully discharged home without any complication, severe complication, I was so happy that we saved his life. But coming back to the history of myself, I felt that I was mostly, focusing on this baby, not the family as a whole. So I think during these 5 years, I have changed my brain or my mind completely. So my next question for you is, so we know that we definitely need families in the NICU. We shouldn't ignore them. But at the same time, are you usually able to take families into account in NICU care or in your practice? Okay, very good. If I were asking this question to my colleagues in Japan, for example, I am sure less than 50% of them say yes. So, well, here's Europe, and I'm sure you are more including parents into the NICU care than we do in Japan. But, well, compared to the 100% answer to the previous question, you see that some of them say no, even if they know that we need parents. So, well, from this kind of a bit difference between these two questions and the answers, of course, we know what to do. But, well, I'd like to, emphasize that, of course, knowing what to do is, different from knowing how to do it or how to implement it. Okay, so the next question is, well, then we now know that it is not easy to do it, implement it, or include the parents in the NICU care. So to do it more effectively or successfully, I think we need to know what is the inhibiting factors for NICU staff to listen to parents or include them in the NICU care. So I'd like to know what is your opinion? What is inhibiting parents to be involved in the NICU care? Okay, lack of time. We have already discussed this issue a couple of days ago or yesterday, I think. Yes, time. Yes, busy. Exactly. And the unit culture, definitely. Yes, this is very important. And the education, maybe the lack of education or something. Staff resistance. Yes, we do have many people who is, opposing to this kind of a culture. Especially during the COVID period, we are, almost totally exclude parents from the NICU. So that's why after the COVID pandemic, many, especially young nurses, says that they don't want to work with parents. So that is, something came up to our mind. Thank you. So the culture and the lack of time, definitely. I totally agree that these are, something we have to solve to implement it. So from my, perspective, one of the key words is this kind of assumptions. So as a profession, NICU professions, we every now and then make this kind of assumptions. I can show you two examples. So let's think about together. So this is the first example. So the day after C-section, do you usually advise the mother not to participate in care because you think she's tired and should rest? What do you think? Good. Again, if I were asking this question to my colleagues in Japan, I'm sure, well, not this many say no, because, well, every now and then we have to, well, do this kind of a practice, unfortunately. And the next example is about the discharge to home. So when discharging to home, I'm talking about the baby, do NICU staff alone usually determine if they, parents have enough skills to care for their baby? Okay, it's well a bit surprise for me, but because I thought in Europe, for example, many of you already involve parents into this discharge plannings. So well, but only half of you include parents in this kind of a decision making. Thank you. Yes, and of course, even the day after C-section, some parents would like to join the caretaking of their baby, even in the NICU. So we have to consider their opinion. And well, talking about this discharge planning, we should include parents because they know what they can and they know what they need for that. It's now half and half. Thank you. So, well, actually, this is my last slide. So this kind of a assumption, or we can also call it professional-driven neonatal care or assumption-based neonatal care. This is something we have to get rid of. So my question today, well, I don't have any concrete answer to this question, but how to get rid of this kind of a professional-driven neonatal care to, well, include parents, or at least, well, take parents' opinions into consider at individual level and the NICU at the NICU level. So these two levels, individual level and the NICU level is something a bit different. So for example, talking about this educational model, it might be, well, a bit easy, or of course it's not at all easy, but for the individual to change their mind, as I did for the last 5 years. But if we want to change the NICU care, NICU culture, then it's much more difficult to change it. For example, in my home hospital in Japan, they have more than 70 nurses and more than 10 doctors. So there are 80 NICU professionals. So, well, to change the NICU care culture, then we have to change not all, but most of their, well, mindset. So it is much more difficult. And well, actually, I don't have any, well, concrete answer to this question, how to do it, especially in the NICU level, how to include parents totally in the NICU level. So if you have any, well, example based on your experience, please share your experience later after our presentations. So thank you so much.
Thank you. And now we are switching slides. Lien de Prost. Please.
Thank you. So I only brought one slide because you already have some background about our research from my presentation on Wednesday. I told you that we have done research with adults born extremely preterm, but we have also done research in the past 2 years with experienced parents in the Netherlands. And we have interviewed, it were individual interviews in contrast to the focus group studies with the adults born preterm. We have done individual interviews with 26 parents with 19 interviews. So in some interview, the partner was present. In our study, all partners were male. And the sample of experienced parents was quite diverse. Some have opted for a palliative care approach, others have opted for a intensive care approach. In some cases, the infant had died, in others, they didn't. Some were twins, some not. If you want to know something more about the demographics of our study participants, please let me know. Our our article is currently under review with Pediatrics. And I have brought some of the main conclusions. This is the only slide I have. And what we have learned from our but first, I'm gonna tell you something more about what we actually asked. So our first question to our parents was, what are your perspectives on a peri-viability guideline, just as we did with the adults born preterm? So that was our first question. Then we asked them, what are your perspectives on personalized care? And we didn't really define this concept. We just asked about their intuitions when they hear the word personalization or individualization of care. And our third question was, how did you experience decision-making in the NICU or prenatally? And what have you learned about that? Our first conclusion was that, as I already give you some information about in my previous presentation, a peri-viability guideline is just as it is for adults born preterm, is very important for parents because it provides support in decision-making and it protects against parental instincts of saving, as I already explained. Second of all, parents preferred guidelines that considered multiple prognostic factors beyond gestational age, and they linked this idea to the idea of personalization of care, because this is a kind of, this guideline that takes into account multiple factors is actually rather implicitly giving the message that their infant is more than just being born at X weeks gestational age. So this is the first aspect really of personalized care. But also they were telling us that it is really important to avoid giving like an overwhelming amount of information, because some parents are just not in need of all this information. Some parents, while being prenatally counseled, they just want to talk about quality of life or how they value life or how they look at having disabilities and stuff like that. So that's the second aspect of personalization, really. You have to ask parents, what do you want to hear? What do you want to know? And what do you want to talk about? Because it can differ. It was believed actually that including more information did not necessarily was not necessary for some parents, for one, but also didn't necessarily make the decision-making process easier. But it has to be personalized. And then third, personalization was mainly defined by parents as being seen, being heard for who they are. And that was actually when we asked, what does that mean? Like, exactly. It was linked to building relationships with healthcare professionals, but also it was linked to sensible, but also effective communication between the parents and professionals. And this is actually a third aspect of personalization, really, because communication needs to be personalized. And this is actually the bonus that I also talked about in my previous presentation. It is not just about what is being told, but really, really about the way it is being conveyed or being told to the parents. And actually, in the article that we wrote about our study, we referred to the concept of mango moments. And I don't know if any one of you has heard about this concept. It was coined in a Lancet article some years ago. And it was not about a NICU at all. It was about one patient in the ICU. And this patient had been in the ICU for a very, very, very long time. And she was telling nurses like almost every day, you know what I would like to do one more time? To taste a mango. And the nurses had picked it up, this idea, and they were telling to each other, like, you know what she said to me? She would like to taste a mango. And also the physicians were picking up on the idea that she would like to have a mango. And then one day the team decided, you know what we do? We just bring a mango to work. So they brought a mango and cut it up to very, very, very small pieces because the woman wasn't really able to eat anymore. But they cut it up in really, really small pieces and helped her eat a mango. And this woman, it were Belgian physicians. It was a Belgian article, she made the news. She was in the news with the message that she got a mango and that she got cared for really, really well because she had been given this mango. And we use this concept in our article on this study because we heard similar stories from parents. We heard stories about how healthcare professionals were asking every day, for example, about the twin sister that had died. Just one question like, how do you feel about this? Or just really keeping or acknowledging that there was a twin sister, for example. And another example from our participants was that there were parents that were staying in the NICU for a very, very long time already. So they only had hospital coffee for a very long time. And they were constantly saying to the healthcare professionals that they would have really liked like a real cup of coffee. So one of the gynecologists brought a real cup of coffee. And it is just about this. It's not about very complicated protocols or guidelines about how to personalize the care. For our parents, at least in our study, it's mostly about very, very small things and just being human, actually. So that's it for me already. Thank you.
Thank you, Lien. We're coming back to the mango, I think. So now we're introducing Mandy C Daly from Ireland, parent of a preterm baby, and you will share your story now.
That's a technical break.
Okay. Hi, everybody. My name is Mandy and I'm from Ireland. So I'm the founder of the Irish Neonatal Health Alliance, which is a multi-stakeholder, multi-collaborative platform in Ireland, and it supports families affected by preterm birth, but it is multidisciplinary. I have a background in healthcare, and in 2006, my daughter Amelia was delivered at 25+6 following a placenta abruption. The INHA is as a result of my journey with my daughter, and 18 years later, we still live with the legacy of preterm birth, and it informs every aspect of our work. So the families that I work with, they tell us that they want their child just to be happy, to be healthy, to be independent, to be socially adept, and not to have the scars of their early arrival. But in order to understand how that can look in reality, we need to just unpack that journey and look at every aspect of the care that was delivered, what aspects had a positive effect, and more importantly, what part of our care maybe didn't work so well. So they tell us that they wish they knew more about the risk factors about prematurity. They want to know more about the signs of complications when their pregnancy started to go wrong. They wanted to know where to access psychological support when their pregnancy started to go wrong. They really wanted to know how to prepare themselves. And that's a difficult one because we don't have the answer to that. And we know that awareness around preterm birth is lacking. We know that it doesn't form part of the normal narrative in school education around pregnancy, and it rarely raises its head in antenatal consultations. Preterm birth, it absolutely flips the paradigm of parenthood on its axis. It robs us of our hopes, our joy, our expectations, our dreams, and we often find ourselves passive bystanders on the sideline, watching others do what we thought we were going to be doing. families end up reframing that parenting role they thought they were going to be taking on. They struggle with their emotions. They can't always access high quality psychological support to help them process their own trauma, but also to help them work out how they're going to navigate this really uncertain journey with their infant. They juggle learning the language of the NICU. They juggle learning the rules, the schedules, the new faces, and they're constantly playing catch up. We know that preterm birth and the NICU experience adversely affects the bonding and attachment process. We know that family-centered care isn't routinely implemented right across the globe. We know there are inconsistencies of messaging. We know that care isn't standardized, and families tell us that they have this sense of inequality when it comes to interacting with healthcare professionals. They are the vulnerable parties and they struggle to advocate for their children. So what do they require? I think families tell us that they want unrestricted access. What does this look like? It can look like lots of things. What it doesn't look like is families coming to the door of a NICU and knocking and waiting for 5 minutes, maybe waiting for more, and catastrophizing as to why nobody's answering the door. So we need this unrestricted access. We also need families to be included regardless of their cultural backgrounds or their religious beliefs. We need families to feel equal in their status as parents and caregivers, and not, whether it's consciously or unconsciously, be perceived as visitors. We do need to educate families how to parent in the NICU. We don't know what we don't know. We don't know what questions to ask. So please don't assume that if we need something, we'll ask for it. We just simply don't know what to ask. We are 10 steps behind where you are at in your normal environment. We need families to know how important it is that they're present. Families are an essential component of their infant's recovery. I'm not sure they don't understand that most of the time. We need families to be part of that shared decision-making process throughout the whole aspects of care. And more importantly, I suppose, because of my own personal story with my daughter, we need families to be educated about how they can continue administering care in the home setting, especially in the areas of motor, sensory, and neurodevelopment. We need family situations to be acknowledged. We need them to be heard. We need their emotions and concerns validated. And every little baby is an individual. They may not talk, but they really are little individual people. And we need to bear that in mind. And I think we need to shift from task-based care to relationship-based care. We need to be practicing precision medicine. We need to be thinking about things like the off-use of medications, the off-label use. We need to be looking at maybe repurposing medications. These are conversations that families, I suppose in my situation, 18 years later, with the benefit of hindsight, can come up with all of these amazing things that should have happened. But these are things that are still very relevant for families 15, 20 years later. So how do we do that? How do we get those families involved, and why? So we need to use that unique time in the neonatal unit. It's a wonderful opportunity to upskill our families and for them to get to know their babies. I remember with my daughter when she was discharged home after 3 months, and it was Christmas Eve. And I remember thinking, they've made a huge mistake. I've never had so much as a goldfish. And they were sending me home with this baby who was really complex, who was still having apneas, and they were going to trust me with her. And I honestly felt by the time I got to the front door of the hospital, they would have come and saved me and brought me back in. And that didn't happen. Why was that? I didn't know my baby. And I think we need to include families in the whole process. And that whole process means getting to know your baby. It means being able to interpret your baby's cues. It means being able to have a look at their physiological signs and learning where they're at on their neurodevelopmental, their motor, and their sensory development. Why? Because we take the babies home. We go home as parents, but we also go home as a neonatologist, a NICU nurse, an OT, physical therapist, a speech and language therapist, a dietitian. We take all of the roles home with us. And we still have to try and parent in a completely new environment again. And it's very difficult. Parents tell us that the transition to home is really stressful and they are not supported, unfortunately. They lose that incredibly important support network. They are the ones who continue to deliver care in the home setting. But are they equipped to do so? And if they're not equipped, what are the consequences? So we know that preterm birth can be for life. It doesn't always end at the NICU. but the medical care pathway doesn't actually reflect that. What we are seeing now is that our adults born preemie are telling us that they need lifelong multidisciplinary care. They need to be able to access care at the right time. They need their health protected. They don't want their health to deteriorate into a crisis before they access healthcare. And even when that does happen, they're telling us that they are really struggling to be heard because some of the conditions they're presenting with are unusual for their age group. And the clinicians they're presenting to don't necessarily make that link between preterm birth and the symptoms that are in front of them. So there is discussion recently around the development of a new subspecialty that specifically manages the health of adults born prematurely. And I think this is definitely going to have to gain momentum if we're going to do justice to this cohort. We know families tell us that they're ill prepared for discharge. They don't know what's ahead. They don't have the education, the skill set to help them continue that development for their child at home. But not only families, community-based healthcare, educators, they also don't receive adequate education on how to manage ex-preemies in the healthcare setting and in the education setting. And this can not only adversely affect the ex-preemie population who are already trying to comprehend their educational, their health, their developmental, their behavioral challenges, but also their families, because they also lack that insight, that support, that guidance to make them strong enough to advocate on behalf of their children. We know research has told us all the domains that are affected. Yet there's a huge disconnect between what research has demonstrated, what families know and tell us, and the services that are available to adult preemies. In the absence of lifelong follow-up, we're missing a really huge opportunity to learn more about how preterm birth affects the community, to learn what aspects of preterm birth affect them most, and how we can do better. How can we ensure that we support them better by delivering all care through the lens of brain care from day one in the NICU? And I'll explain why in a few moments. How do we support families on their whole journey? And also further on, when we're developing services, these need to be co-designed and delivered and informed by those living with preterm birth, not for them. So we all accept that survival is no longer the goal. But we really do have to do better in terms of the care we deliver to make sure that it supports our families and our infants to thrive. So my daughter, Amelia, she's nearly 18. Every day she wakes up as a preterm baby. She lives with a whole bunch of challenges. So she lives with them, and I suppose by default we do too. So she has sensory processing disorder, which affects all 8 of her senses. And I can't imagine what it's like to live a life like that. She has developmental coordination disorder. She has avoidant restrictive food intake disorder. She has an oral aversion. She has BPD. She has a facial deformity, which has resulted in surgery on a few occasions. Her facial bones were deformed as a result of a long-term use of a CPAP mask, and it still hasn't been resolved. So she lives with daily facial pain. And unfortunately, her reaction to pain is flipped. So Amelia will feel pain if you prick her with a pin. She will just fall over like you've shot her. But if she falls and breaks a shoulder, she doesn't feel that type of pain. So it's very difficult at times to understand what is going on in her body just simply by just judging her reaction to pain. She has executive function disorders. She has fine and gross motor issues. She has generalized anxiety. She has huge anxiety about her health because she's getting to that age where she's beginning to learn. She's a bit different. She learns differently from her peers. She learns through movement and through sound. She has some emotional problems. In recent times, she's also started to have a lot of circulatory issues and cardiac issues. And she's 17 going on 18. And I know she's thinking, where is this going? What's going to happen? We don't have the answers. But if you were to ask me as a parent, what would have made a difference? What are the 2 things I would pull out of this short presentation that would impact my family hugely and would have a huge reach if it were implemented? It would be to consider that all care is brain care and that all care must be delivered through the lens of brain care, and to always remember that preterm birth is for life and that everything that happens in the neonatal unit has an effect, whether it's positive negative or cumulatives. And thank you.
So thank you, Mandy, for wonderful talk. Very strong. So we're now moving the chairs together, and we can keep the slide open. And there is one chair missing, but you can take this one. Oh, okay. You do the stand. So, where to start? Let's see what Slido says. So, is there somewhere you want to start? Any one of you? Please.
Shall I ask a controversial question
Yes.
that kind of comes from Ryo to begin with, from his word cloud? Do we really think that time and lack of time is a sufficient excuse to not be seeing parents as the partners?
Well, of course, it's an excuse, but at the same time, we cannot. Well, it's not at all easy for us as a profession. We're just working in a NICU to change the situation. So it's more, say, governmental or organizational level who have to change this kind of a situation. So I think it's a excuse, but at the same time, it's not at all easy to change the situation.
Anyone else want to come in on that?
Yeah, I agree. I mean, and I don't like using the word excuse. It's the reality of the situation. You know, it is a really high pressure environment. You're under-resourced, you're understaffed. But I do believe some of these high level issues can only be solved and resolved through a collaborative effort. And it's not simply clinicians who can take this on board. And I think that's where we miss out in this community, is we don't often work collaboratively with cross-stakeholder involvement. It's what we try to do in our own way in Ireland, and I think it's replicated in certain pockets. But this is a global problem. Like, these children may have issues for the rest of their lives. A lot of what we do in the NICU can have an effect. How do we work together? How do we interact with other stakeholders? I think it's important to start thinking about that, and maybe our leaders in the various societies can come together and start the conversation. It's not going to be resolved overnight. And I think it shouldn't be used as an excuse, but it is the reality of the situation.
I don't think I have anything new to add, but I do think for certain aspects of personalizing care, time could be an issue. However, there are also research studies that have looked into how much more time shared decision-making, for example, would take, and not so much more, actually. So for certain aspects like shared decision-making, it's just a culture shift instead of the need for more time. However, I do understand that there are institutional difficulties, challenges, yeah.
Well, thank you. Well, I totally agree with you. And well, I think the point is what to prioritize. So for example, well, to use this time for writing the medical record, well, rather than that, we can use that time for family involvement, for example. So, well, in this way, I think what we need to do is to change our mindset. Of course, it's not easy to make longer time for this, but we can, well, bring some time from somewhere else.
So what are the, I mean, you said stakeholders. This is a word that is not so much used in healthcare, stakeholders, but it's very common in business and human sciences and so on. But how would parents be able to influence and change the way we perform care and the way we do research what would you, how could we change?
That's a very broad question. So I guess I spend a lot of time working in research and education. I'm an embedded patient researcher and have been for the last 12 years. So I am involved from outset in all neonatal studies that happen in my country and internationally where I can. Parents are the ones who are now being asked the question, what do you need? And I think that's a really good, important start. I have noticed on a couple of occasions in the last couple of days, people saying we had a research question and then we went to the parents to see how we could design the study. That's one step you've got it wrong. You need to start way before you're even thinking about your hypothesis. That's when you start to engage your community to understand really how that illness, that condition is affecting them. That should be driving what the research question is, not you going to your patient community saying this, we're thinking of looking at this, can you help us design a study? Because that's just one step too late. In terms of changing policy, a lot of patient organizations are really active in the policy space. We have been very successful in Ireland. We have helped extend a transport service from 9 to 5 to 24 hours. We have got neonatal guidelines instituted. We have had therapeutic hypothermia register set up. We have changed the law on maternity leave. So in terms of working together, patient organizations have often been the instigators of collaborative stakeholder involvement. And those stakeholders right across the neonatal sphere don't just include clinicians, it's nurses, it's policymakers themselves, it's industry partners, it's researchers, it's educators, and it's trying to provide them with a platform because as clinicians, you're not skilled in diplomatic conversation. I'm sorry, but you have a particular skill set, but you have a very important skill set that forms part of a larger picture when it comes to policy making. And I think you need that driver behind a project that helps you join the table and bring your skill set and then hones all the skill sets that are there in order to make change. And I think change can only happen collaboratively, and it has to be one group, whether it's a patient group or whether it's researchers or educators, has to take ownership and then be in a position to gather all those stakeholders together and extract the important skills from each stakeholder that will serve them in whatever project it is, whether it's changing care, whether it's increasing funding. It does happen internationally, but I think we do need to step outside our own comfort zone at times and wonder who else do we need at the table. It's called a stakeholder mapping. We all do it. Like my background is in radiography. I don't think for one second I ever thought I'd be here as a parent, but life has changed and I've upskilled. But it is collaborative and it's timely. It takes a lot of time.
I really agree with your point, with your first point, actually, that parents and patient organizations are actually involved few steps too late. And in the Netherlands now, the patient organization, for example, is also involved in reading protocols before they go to ethical committees, in reading interview guides, in discussing research questions, not just reflecting on how it should be answered, but really the question, is this a good research question? Is it valuable to even look into answers for this research question? And I think that's a great shift that is happening. But it
does take time. Like in Ireland, not only now are we involved in designing the hypothesis, we also are involved in study design. I work with our funding agencies. I decide who gets the money. I also then work with our National Research Ethics Office. So every single study comes across my desk, whether it's in the neonatal space or in the neurological space or the pediatric space. So now we have patients embedded at every point that we can. So the research makes sense. It only gets funded if patients say it should get funded. We also have an ethical eye to throw over it. And we're also involved in recruitment, in actually conducting the studies, in the dissemination of the studies, in writing the papers. So I think we need this cultural shift takes a generation. This was not happening 10 years ago. This happened because I kept on knocking on doors and saying that it really needs to happen, and this is why it needs to happen. And thankfully, it has. I've been very lucky and privileged that in our country, they have all the different stakeholders have opened the doors at the same time, and it's very fortuitous. And I can't take credit for that. That just was timely. But in terms of working with patients, they make a change, but they need to be not only involved. I am involved in clinical guideline reviews. I do clinical audits. Again, stuff that most people are horrified at when they realize patients are doing that. But these are the things that patients can help do. If they start doing stuff like that, you can then work together and build that relationship. So when something large comes along, like a policy change, you already have that established relationship with them. I'm silenced everyone there now, so.
So I'm just thinking about who is, like a practical perspective, who is doing what and when. And do you think the neonatal community could be the driver of change, or is it more a societal, political stakeholder question? I mean, are we as neonatologists and nurse practitioners and physiotherapists, and are we sort of able to do change?
I think it starts here, because now even in the neonatal community, there is not agreement on even the fact that parents should be included in protocols and research and audits, because it's, yeah, I mean, it needs to start in the neonatal community. Also, gynecologists and neonatologists often disagree on very, very vital things and care practices. So it starts there, but then there needs to be, of course, broader society involved in the discussion and reflection. And also we were talking about schools, even teachers needs to be aware of consequences of extreme premature birth. Primary healthcare practitioners, yeah.
So what we do again is we now go, we teach in secondary schools. We also teach in medical colleges, and we teach nursing staff about preterm birth. We teach teachers who are in training about preterm birth, because we believe that all the stakeholders who are going to interact with preterm children need that skill set to serve that community well. We're designing a new group called the Prenate Hub, which is like an education portal for those who are not involved in neonatology directly, but who will ultimately interact with another preterm infant. So like the teachers, the community health care, social care workers, because they just don't know, and they don't know what questions to ask. And as a result, you end up like me, spending years trying to get a diagnosis for a child that you know is compromised, but you don't have the language or the necessary connections to get a diagnosis. And that's what we need to change. But I think we do need to start somewhere. And I think as a community, even changing your own behavior, even in changing how you work, how you do research, that's a good example. That is an example that those coming up behind you, that you've changed. You've decided you're going to do it this particular way. You're going to involve patients. At some point, it's going to be normalized, hopefully. But I think it only comes around by you yourself making that personal change, and it does gain momentum. I mean, I'm doing this a long time, so as I said, a long time ago, this was not why I got into doing this. I got into this area because I needed support as a parent. I knew that on discharge, I was not skilled. I didn't believe for a second I could take care of my child. I thought I was going to kill her for about the first 3 years. I set up an organization to support me, and this is where that journey has taken me. So I guess what I'm saying is change does happen. And it can't be fortuitous, and maybe in my circumstances it was, but I think you need to change your own personal behavior first, and that will reflect outwards.
Thank you. I totally agree with you. Well, at least, well, first of all, I'm very surprised or impressed that you already have a good involvement in this neonatal care from the parents' perspective. So compared to the situation in Europe, or at least in Ireland, for example, in Japan, families' involvement is quite low level still. So in this kind of a neonatal context, I was wondering what we can do even in this kind of a situation. And I think what is the most important thing for us, at least, is to, maybe listen to parents or change our mind. Because this is, something, the basic things we have to do it. Otherwise, maybe parents cannot be involved in any decision making or the guideline making or something like that. And this is of course a very tiny and small step, but at the same time, we should start with this kind of a small step.
Yeah, I agree. Cultural differences have to be taken into account. Absolutely. And you can't just jump from step A to step Z very quickly. But those tiny steps at the beginning by involving parents. And as I said before, parents don't know the questions to ask. So therefore, you do. This is your normal life. And by involving them in the day-to-day care, you're building their confidence. And at some point in the future, you will see that that confidence will permeate out into other areas beyond just providing support. And it does take time, but once momentum starts, I think in this area in particular, when parents start to see that they are confident in themselves as parents, I think they will then realize they have another ability that they can now advocate on behalf of a community, not just their own child, but it has to start at an individual basis.
Maybe I would have some rotten tomatoes thrown at me now, but I'm not so sure that like NICU staff would be good initiator of change, because what we hear in the follow-up clinics, for example, is that some parents, they express some frustration about the gap between the huge investment in intensive care and XYZ, the first, say, 3 months of life, and then it's bye-bye and see you later, and there is no solid follow-up or backup or support in the near and longer future. And I'm not sure, I mean, in the NICU, we're good at looking into medical things, but we don't have the full picture. So I'm not so confident that we could solve this. I think it needs to come from, I think we need to be pressurized a little bit. So it's a bit controversial, and maybe we'll want to add something in Slido now, but what do you think about my comment?
Well, I think in individual level, for example, what is important is to, well, change, well, the change in the responsibility for the care of the baby. So at the beginning of the admission to the NICU, of course, almost all the responsibility should be, well, taken by neonatologists or NICU nurses. But then gradually parents have to, well, take these kind of responsibilities. And the end of the NICU life, all the responsibilities should be taken by parents. So if this kind of a transition is well done very smoothly, then the problem may not happen. But well, nowadays, for example, in Japan, this change happens very quickly and shortly before discharge. So when there comes a discharge, say a week later, then we quickly prepare parents to be ready for discharge. So this kind of a quick, change or tradition in the responsibility is something problematic, and we have to think about it to improve it.
Well, I'm an ethicist, so I'm going to give a controversial answer to your controversial question. And at least in the Netherlands, the two main groups who are responsible in guidelines for treating extremely premature infants are gynecologists and neonatologists. And if these guidelines state, or maybe if these guidelines result in the fact that we, for example, resuscitate infants born at 23 weeks, then it is way too easy to say, well, we decided to treat them, but then growing up and follow-up is not our responsibility. We just have to have them survive, and then the responsibility is for society and social workers. And because that, I don't think that's true, because the people who are responsible for the guidelines are responsible for the existence, actually, even to be a little bit more abstract, but of these infants. So you're also, I think, responsible for their lives in the long run. But that might be controversial as well, so sorry.
I think the follow-up is particularly poor. There are very few places, I think, that I would quote as being ideal. Follow-up has to be for life. There's no discussion anymore. I mean, we're living with adults who are born preterm, and some of their lives are very difficult. I work with a lot of them, and they are the forgotten community. And I think that word was used in one of the talks a few days ago. And I think ethically and morally, we owe it to them. I feel guilty that my child is as good as she is. And I mean, given what I just listed out earlier on, doesn't sound great. But she's really good in comparison to some of the other adult ex-preemies I work with. And I think unless somebody starts this conversation, and sometimes these conversations start somewhere like here and somebody picks it up and runs with it. They need to start though in several different locations. It cannot just be in one country. We are hearing adult ex-preemies the world over telling us the same story. So I think the momentum is actually there. We may not have heard it yet, but I certainly see it on the ground. I see that adult community starting to come together, starting to advocate on behalf of themselves. I guarantee you within 10 years, the adult ex-preemie community is going to be a very strong voice in this space. I guarantee you, because I can see it happening. So whether they're the ones who will start the advocating and they will be the ones who will lead this project, yes, but it does need everybody else who's been involved on the way, because you know what work you do, and you also know the work that you do that can adversely affect or can positively affect, and that is such an integral component of any of the policy making at the other end in terms of follow-up care. Your voice needs to be at the table regardless.
So that's quite an interesting point, that you think that preterm or adults born preterm will be a significant voice in the future. I don't think at least I haven't seen that yet. But this is an interesting prophecy, I think, yeah. And I'm also thinking about, we heard, I think 2 days ago or yesterday, about when we had the Nobody Wants to Work Here discussion, that there is some public pressure in the UK that parents are like accusing obstetricians and hospitals for bad things happening. And maybe this also could be also pressure on healthcare to do differently or include stakeholders in a different way and so on, and think through what are we actually doing and why and so on, and for whom. So, yeah.
I think in terms of follow-up, nobody has actually quantified the cost of treating ex-preemies as they get older. And I think if we were able to have a health economist do an overview of the cost of not providing adequate follow-up for, I'm going to say 10 years, 20 years, versus the cost to the healthcare system of these infants constantly re-entering the health system at various junctures of their life, we would be horrified why we're not investing in follow-up care, but that hasn't been done. And again, none of us here is a health economist. I'm not a health economist, but I do know health economists do this work. So who do we get? How do we get health economists to start hearing us? I think we need to bring them to conversations like this. They need to be here to see what the problem is, because again, they don't know that it exists. When I went to try and advocate to get funding to get our transport service extended to 24 hours, all of those on the health committee in our government couldn't believe it wasn't there already. They just didn't know. So we can't assume that people know what the problem is unless we go out there and publicize it.
In our study, also some adult preemies were actually convinced that if you provide really good follow-up care, it would actually, in the long run, be cheaper than what we're investing now, because they're getting wrong diagnoses. They're visiting many hospitals, many different specialist physicians, which is actually very bad for the healthcare system in general. So our adult preemies would even make the argument that it is cheaper to provide good follow-up care.
There are lots of comments in the slide, or maybe not so many questions, but one suggestion is that we should invite an ex-preemie adult as a speaker, for example.
We've actually already spoke about this.
Yeah.
We have her here next year.
Yeah.
Watch the space.
Another question I'm thinking about, what are your stakeholder reflections from our discussions over the last 3 days? Do you have did you get any thoughts about, were we speaking about the right things? Did the sound of silence, is that something that would really matter to families or not? How did you feel about the extremely preterm or limit of viability debate? Please.
So everything that I heard the last 3 days was incredibly relevant. It all resonated with me because obviously I do have a personal story. So when I hear about limits of viability and I hear about the sound of silence, and I'm thinking my life is living all of these. Like my daughter has sensory processing disorder, so sound is a big problem. Sleep was an enormous problem for years. So it is all relevant. I think parents don't realize the broad spectrum of issues that can arise as a result of a child being preterm. We don't have those conversations with them, and we end up navigating our way through soup to try and find out what's wrong with their child. I know you heard me talk in UENPS about my child has BPD. My child never slept from the day she was born. She went home and she would cry. She would not go to sleep for starters. She'd sleep for 2 hours and wake up screaming. It took me 9 months to realize that because she had BPD, she was struggling to sleep on her back because positioning is really difficult for babies with BPD. They don't like lying on their back. I wish someone had told me that. It took me 9 months. And this is the sort of stuff when I learned so much from coming to conferences like this because it is a reflection on my daily life. So it is very relevant. The conversations around the 22 and 21 weekers, I slightly struggle with that because I just feel we don't do them justice at the other end of the care spectrum. And I think we need to constantly remind ourselves we shouldn't be doing it because we can. And I know that sounds hard, but there are lots of families out there who will tell you that their lives have been changed forever by having a preterm birth. There are plenty of relationships out there who have finished because of preterm birth. And they're the consequences we don't see in our neonatal units. It's a particular time frame that you see, and there is a much larger picture. So the conversations the last couple of days were very relevant. They were very thought-provoking. I really enjoyed them. I've taken a lot of notes. But I think families probably need to know a little bit more. I think we don't do enough justice to our families. We don't tell them enough. We don't fill in the gaps. And we are the ones then who end up, I suppose, trying to upskill ourselves for the good of our child. But it's often too late because by then a diagnosis has been missed.
So related to that about shared decision making, there are several comments or questions about this related topic. So how would parents, if we now think about the short-term NICU environment, how would you see parents, how would you like to see parents be engaged in medical decisions and being the voice of the patient? I often think that who else could be a better proxy than parents? In Sweden, and not so many Swedes here, but we have this saying that the doctors are the lawyers of the children. We can sort of defend children and give them care if they need and so on. And I'm not so sure this is a good expression because, I mean, who else could be a better decision proxy for a child than a parent? But so this is now a long reasoning, but how would parents generally, but also personalized in a personalized manner, want to be engaged in medical decision making? Is it the right thing that parents should have a lot of influence, like maybe in the Netherlands? Or, yeah, please.
Okay, so I think for starters, there's a huge imbalance between parents in the NICU and the caregivers. Parents often don't even realize they have rights, that they can speak on behalf of their child. And I think we need to start with that conversation early on so that they understand where they are, what their role is, what we expect them to do, because parents don't understand. A lot of people don't understand the whole concept of consent. I give an hour conversation, I give a lecture on informed consent because I feel as individuals we're very poor at it. So I think those conversations need to be had first, so parents are aware that they're equal partners, that shared decision making is a thing. At that point, then you have to personalize it because not every family wants to know. People communicate in different ways. People are not sometimes. They recognize that you may be the expert in a particular area. sometimes they assume you're an expert and you may not be. And that's a difficult conversation when you say, we don't have the answer for this and we're trying this experimentally. But I think we need to be very clear with parents from outset that their role is as an equal partner in the NICU environment for as long as it's home for them, and that their opinion matters. And I think we need to just be very clear about that. That is something parents don't realize, that they do have a voice. And I think sometimes we need to remind them they have a voice. They're very vulnerable, they're traumatized. They don't know if their child is going to live or die. Their ability to rationalize is probably poor, which means that we have to be very clear in our messaging, in our communication, and that it's documented. My daughter was signed up for a clinical trial on day 2 in 2006. And I honestly don't remember reading the patient information leaflet. I don't remember giving informed consent. I'm sure I did. But in hindsight, I look back and there are moments of my NICU journey that are not there. They're gone. So I think we need to be aware that the families we're engaging with do need that extra support, and that when it comes to informed consent and shared decision making, that they feel comfortable doing it with us, and that we constantly reflect back with them throughout their journey that they are aware that, you know, their opinion matters, and that they do have a difference of opinion, that it's okay. We'll sit and talk about it.
So the three of you all have like expertise in this topic, and there's one question here. How do you think, or what would be the best way to find a balance between involvement / information? Like, how do we fill in all the gaps between overwhelming parents with information and involving them?
Well, for me as a researcher studying this family-centered care, I think the individuality, or considering their personality, well, the difference, maybe it's the most important thing. So every parents are different. So some parents may be overwhelmed by many information, but maybe another parents may not. So what is, I think, important is to see that person and change your way of communication. I think this is one of the important things from my perspective.
Yeah, I definitely agree with that. And also, I think we can learn from other disciplines, because, for example, we know from other fields that there is this thing called clinical nudging. So if you present information in a certain way, you will influence people's decision making. So, for example, if you say X% will survive, or you say X% will die, it will influence people's choices, and we need to be aware of that. So I think we can win some also by extra education and teamwork with other disciplines. In the Netherlands, certain hospitals have a department that is called medical decision making, who are specialists in topics like this.
Okay, for me, I think it's very important that we check in with families constantly. So when we meet the families at outset, we're aware of where they are. We're aware of on that trauma journey they are. We do record families' preferences, and we ask them constantly. We'd say, like, you know, do you want to be wrong in the middle of the night if we have to reintubate? So we ask up front, because families don't know. They don't know how the NICU operates. They don't know who makes what decisions, and we're very clear with them. We're very honest, and we speak in lay terminology, but we will always check back on those decisions and say, are you still okay if we don't ring you, if we have to reintubate? So it's giving them the different clinical scenarios where they can be involved and offering it to them as a suite. They can either opt in and opt out of various things, but it's documented on their file. It's about including them and letting them find where they're comfortable. They don't know, and they won't know until we dip their toes in the water to see what information they're comfortable with. And they do get overwhelmed, and it's okay to take a step back. But I think we have to be always cognizantly aware that everybody's an individual, and how people process information and react to it. We have to be very clear about looking at people's body language, hearing the tone in their voice. And I know that's not something you're trained to do and you don't want to do it, but that will tell us. Sometimes what they're not saying will tell us more than what they're saying. And I think sometimes listening and observing tells us way more than hearing the actual words. So I think it's a big question for which there's no answer, but I do think we just have to be, it's not all about just what should we, what shouldn't we do? I think it's individualized, and I think how we do that is maybe slightly different, but I think we just need to be very cognizant that we are the ones who know more than them, and we have to constantly check in with them to see, are they okay with the way we're doing it? And it's okay for them to say they're not, and it's okay for us to say, we're looking for your feedback. We want to do what's best for you. We would love you to tell us, to guide us. At least that's part of that inclusive process also.
Both mixture. Thank you very much for this talk. It was very touching. We all agree probably that the presence of parents is essential for the development of the infants. But what do we do really for parents? So, like, I mean, in terms of psychological well-beings, for example. And another point, it's a kind of political point, because you're mentioning parents need to be there for the baby, but in which condition? And probably think about, I don't know, the mother is usually there, but the father has to work, or you have other children at home. So how can we care for the parents that both have the energy to stay within the NICU for their children? I think that's a missing point, and probably involve politician, but also a good psychological team to support the parents. We never mentioned the word psychologist in this round or in general. And I think emotional support, emotional bonding, it also probably deviates the trajectory of the outcome, as well as the energy we can provide from the political point of view for both parents to be in the NICU. So will you comment on that? Is something changing, for example, that both parents can be at the NICU, that both parents, for example, can take a break from their job and be there? Yeah, thank you.
Yeah, that's actually happening in pockets. I won't say it's uniform. There are countries who will give paternity leave to fathers. I think politically that's something that we definitely need to focus on. Fathers are the lost group also. They return to work after 3 days. They are psychologically affected in a very different way to mothers, and how they manage and process trauma is very different. We do not care for them. I think we do better with mums, and I think a lot of our neonatal units do have access to psychosocial care. Is it specifically for the NICU? Maybe not. It's hospital-wide, and I think we need to do much better in terms of self-care. We as an organisation offer a self-care program to families because we recognise that the care is not uniform, and we recognise the pitfalls that families are going to encounter. So a lot of patient organisations are picking up the pieces in terms of offering self-care. Again, it's another issue, I think, that you're right, needs to come from the top down. And I think dads in particular are completely lost. I really feel for them, because they go back into the real world. Mums get to live in that bubble for a few months, which is not fun, but at least they're spending the time, and you say they're bonding, they're attaching with their babies. They may not realize it's happening because nobody talks about bonding and attachment, which is a different conversation, and how important it is. But I think we don't do good. And I don't think we have enough psychologists present at neonatal conferences, because they play a very vital role in that family's recovery. But I think they also need to see the rest of the picture for them to do their role right. And we don't bring them on board. We don't have them at the table. And again, there's a gap that needs to be addressed.
Shall we have one final question, do you think? I guess we started off by saying that the change maybe starts with us and starts here. So perhaps you could all try maybe to give us one sort of practical thing that we could all go away and try and do or implement. Is there a single, where would we start? What one thing can we all kind of take away from this to start making the change?
Which change?
Any
We
change.
talked about a lot of change up there. Okay. Okay, for me, I guess I'm going to personalize it again and say, in terms of the care we deliver, I think we need to constantly remind ourselves that everything we do in the NICU has an effect. That could be a positive, negative, or cumulative. So every single time we go near a child, take those 10 seconds and ask yourself, Is it necessary? What are the consequences? What has the day been like so far? And what could the possible sequelae from my intervening here be? Because all brain care, if not all care isn't delivered through the eyes of brain care, we have a problem.
I'll stay rather abstract, but I would say that voices can only really be heard when someone really, really listens. So I would say, listen.
Okay, I totally agree. So, well, again, may I repeat that parents are different. So, well, well, they're different. So, well, to know them quite well, then all we have to do, what we have to do is to listen to them so that we know more than before. And this is something we can do. It's again, a small step, but we have to, well, go through this kind of small steps so that we can achieve more.
Thank you for those final comments. And thank you so much for taking part of this panel discussion about what matters to families. And I think the last or the second line here is also very, that preterm birth is for life. So it's something that we will also hear about more when the preterm babies grow up and become adults and start to write in newspapers and
Speak at conferences.
So I'm looking forward to this myself. Thank you so much.
Thank you.